And welcome to another episode of Longevanity, where science unites the intersections of living your best life, looking your best, feeling your best, and trying to embrace everything that life has to offer us. So, my name is Dr. Amber Bocknek. I am a physician here. I practice in Ontario, Canada. And today we're going to focus on some hot topics in anti aging and wellness. So, I just want to thank all of you for coming along on the journey and welcome all of you here today. So, before we get started, one of the really important things to do is just to make sure that everybody knows that the content that we discuss here is truly intended to be educational content. So, this is not meant to be personal medical information. And so, everything we cover today is really meant to be a talk point, something to stimulate conversations. And if there's something here that resonates with you, I would really encourage you to pursue this further with your own primary care provider, whether that be a family doctor, your nurse practitioner, your gynecologist, an internist. But again, make sure you seek your own professional health advice. And if you're going to action on any of these things, make sure you're doing it with guidance with somebody who knows your personal health the best. So with that said, let's launch right into today's discussion. So I don't know if all of you have been following what's going on these days in the United States with hormone replacement therapy. But if you weren't aware, the FDA is the regulatory body in the United States. Health Canada is our equivalent up here. But the FDA had what was called a black box warning on hormones. So for estrogen, progesterone, these medications have big warnings on them. And the black box warning is probably one of the most serious health warnings you can provide. It creates a lot of attention, negative attention, and fear around those medications that it's applied to. And again, in some situations, of course, this is completely with merit and we need to be careful. But this is just recently, this past week, box warning has been taken off of women's hormones, off of estrogen and progesterone. This has just created so much excitement amongst the medical community and in the patient realm, and women out there everywhere who have been experiencing issues with hormones. Let's talk a little bit about the context of all of this. This didn't happen in a vacuum. About 20 plus years ago, and really it hasn't been that long, 2 decades ago, there was a study that came out called the Women's Health Initiative. And the Women's Health Initiative took a look at hormones, and they were measuring for all kinds of outcome measures. And what they found at that time, now fully debunked for the greater part and erroneously interpreted, was that their findings then was that hormones were dangerous, quite frankly, in a nutshell, is what they kind of concluded from this study in a couple of different regards. So they looked at estrogen, and in the estrogen that they looked at in the study, they thought that it increased the risk of cardiovascular disease and that they had some difficulty, although showing some protection. They couldn't justify the benefits against the risks. On the progesterone side, they lumped progestogens, which sounds a lot like the word progesterone, but it's different, similar but different, and the difference is important. But they took the whole category of both real progesterone and progestogens, which are synthetic chemicals different from progesterone, and they found that that increased the risk of breast cancer. And from there, the black box warnings came, and people were pulled off of hormones quite widely, or a lot of fear was placed. And I think we really have to take a good look at that study as well, and those interpretations. So a few things we learned, and again, I would kind of use the expression throwing the baby out with the bathwater when it comes to this study. They looked at certain things in North America, and again, North America different than the subsequent studies that came out in Europe that were looking at more similar real hormones to what humans make, or what we call body identical or bioidenticals. The ones here in North America were not. So In this study, primarily at that time, the two front runners on the estrogen side that were widely prescribed was one called CEE, which stands for conjugated equine estrogens, and the other one was Premarin, which comes from short from a pregnant mare urine. So if you picked up on it, these are horsey estrogens. So we were giving human patients widely oral horse-derived estrogens, which have different components in it than what humans make. So a couple of problems there. Number one, they weren't species specific to humans. They had other things. And the other thing that was interesting, particularly as it pertains to estrogen, is these were oral estrogens. And those are the two main problems that we had from that study, which we understand now. We didn't understand that back then. The problems, the fallout really are as follows. When you take estrogen orally, and this is really a problem with estrogen, it's not the same issue with progesterone. We'll talk about this in the next moment. But oral estrogen, like any oral medication or any food for that matter, goes down through our digestive tract. Why might that be a problem? Well, whether it's food or medications, the substances that we ingest are broken down, affected by the gastric acid in our stomach and other digestive enzymes, like in the food process, to break that down into little itty bitty particles that we can absorb. And then, whether it's food or medication, as it enters into the parts of the intestines, then those molecules start to cross from inside the intestine through the wall, ultimately ending up in the bloodstream to be carried to the liver first and then to the rest of the body. So when this happens, the direct next place, the next destination on the pipeline, basically from being absorbed, is the liver. The liver would take these horsey estrogens and then make metabolites from them. The metabolites were really where the problem was. They caused a lot of issues with increasing blood clotting. And so blood clots, stroke, heart attack, we saw increases in those problems, particularly because of the way it was metabolized. Now, this is an issue for all estrogens, whether they're human, body identical or bioidentical, or synthetic ones or ones that come from other species. If we give estrogen orally, that remains a concern. However, that's not the only way to give estrogen. There are other routes, other methods of estrogen intake that don't involve ingesting it orally. So some of the common things that we can do as alternatives would be patches. So yes, you can get bioidentical or body identical estrogen via a patch. And that skips the whole issue of the metabolites from the liver where we see the clotting risk. And also you can give it as a cream or intravaginally. It comes as rings, as intravaginal creams, little tablets that dissolve. So lots and lots of different ways to give estrogen that skips that whole liver issue that way. So that's estrogen story. Progesterone, here we have to really be careful about the naming. So progesterone is different than what a progestogen is. A progestogen is a broad category that, it, as an umbrella, includes bioidentical or body identical progesterone, the stuff that we make, as well as chemical elements that are meant to mimic the functions of natural progesterone. But the issue is with the other synthetic agents, they aren't actually progesterone, they're different. They have some similar properties to progesterone, but they also have different nuances, and the devil is in the details. So the nuances of the progestogens are actually what we better understand now to be what was involved in some of the issues around breast cancer risk. We don't see that increase with the body identical or bioidentical progesterone. Now, we just finished talking a moment ago about some of the concerns around oral estrogen. We don't have the same concern with progesterone. Why? That sounds like a double standard. You take it by mouth, it goes down the digestive tract, it gets into the small intestine, it gets absorbed, it goes in the blood, it goes to the liver. Correct. But we have different metabolites from progesterone. So ultimately, when progesterone is being metabolized in the liver as it goes through there the first time, its metabolite, or one of the metabolites, is something that promotes GABA. And GABA is a very wonderful calming neurotransmitter. So we actually use GABA and make GABA in our body in other areas again, for use irrespective of taking oral progesterone. So it's a naturally occurring thing that actually shows benefit and helps. GABA is really important in calmness, in quality of sleep. So again, one of the issues we see when women are naturally losing their hormones, and progesterone often is one of the first to decline, is that they are anxious, can't sleep very well. So again, using progesterone orally can sometimes be very helpful. If there are issues not to use oral progesterone or the person is uncomfortable with it, there are alternatives. Progesterone can also be given through creams as well. So that's another option too. So we can give it topically, we can give it orally, but we do have ways to give it. But the big thing is now is that finally this 20 plus year specter from the Women's Health Initiative is finally being recognized formally as being some of the conclusions being quite frankly erroneous and misleading, but in a negative way. What has happened? Well, there's a generation of women who have basically been told that hormones are dangerous. So I'm in that sort of midlife demographic now in my 50s, but anyone who would be my mother's age, or if you're similar in vintage to me, your mother's age, these are the target women who had hormones withheld. And what we've really seen is an increase in all kinds of future potential problems that we can mitigate to some degree with consideration of hormones, like frailty, fractures. We definitely know that osteoporosis can be prevented in many situations or reduced in severity by the use of hormones long term. So again, we see a much higher incidence of osteoporosis in our mother's generation. Dementia, there are cognitive benefits from hormone replacement. So we have a lot of women who are 70 and 80 years old or older, and again, they either were on hormones and had them abruptly stopped, or they were denied hormones. So again, we see a lot more cognitive impact in women, particularly this particular generation of women who did not have access to that care. Cardiovascular disease, if we start these interventions early, close to perimenopause, menopause, again, there's a reduction in cardiovascular events with hormone replacement. So again, another talk point or touch point to chat with your doc. And again, the uses are increasing and expanding. There's the whole discussion around quality of life and symptoms. For women who are really actively in menopause, sometimes they find that they have profound quality of life altering experiences. They just don't feel like themselves anymore. They don't handle stress the same way. They don't have the same mental clarity. They get flustered really easily. Problem solving ability isn't the same. The brain fog, the lack of sleep at night, the hot flashes, the night sweats. It impairs their genital urinary function. Intimacy can become painful. Bladder control, increased urinary tract infections, so a whole host of different problems that can be helped with it. Now, as far as personal risk and concern, this is definitely an area where you want to talk with your doctor or your primary care provider about this. We have a bigger and broader spectrum of patients who are eligible now for hormones. 20 years ago when I was already in practice when this study came out, the Women's Health. I actually graduated from medical school in 96, so I've been around a while. And I was in independent practice as of 98. I finished my residency, and I was prescribing these medications back then, and I remember clearly taking these women off of them. One of the other things around that time already, or prior to that time, we also avoided women who we realize now actually are candidates still for hormone therapy. So specifically, I'm thinking of higher risk women. In that category, I would talk about women who had a first degree family member. So a mom, a sister, grandma. You might not offer those women hormone replacement therapy back then. Now these women can have a conversation about it. They're not necessarily excluded at all. So it's one of those things where we have to look at the individual risk factors and what constituted that, but we understand better that breast cancer is a multifactorial type of disease. It's not just one thing that puts you at risk, like family history. In fact, it's a host of different things that increase risk. But having a positive family history does not mean necessarily at all that you're not a candidate for it. Another group of women who we now entertain the possibility of hormones for are women who have actually had breast cancer. Now, this has to be done carefully under consultation with your primary care doctor and your oncologist, but more recently, just in this past year, in 2025, there's a study that has come out looking at breast cancer survivors, actually, women who have actually had the disease. And they divided these women into two pools. One group, after their full complete treatment, received hormone replacement, and the other group, after their full treatment, did not get any hormone replacement. And they were looking really for two major outcome measures. The first was, of course, did they have an increased risk of recurrence of their breast cancer? And the second thing they were looking at, did their overall quality of life or their other causes of disease or death go down or up? So they were looking at both breast cancer impact as well as sort of quality and other diseases that we know are impacted by the presence or the absence of hormones. So what's really fascinating about this group, and the reason why I like to talk about this group of women, is that these are the highest risk women of them all, the ones who've actually had cancer, because we can take some of the things we learn from them and we can use that to have a reasonable, rational discussion about women who have a family history or have other individual risk factors to try to assess their individual risk. So here's the conclusions of that study. So the women for recurrence first of getting breast cancer again after they'd had it, in the two pools, whether you got hormones or you didn't, had basically statistically the same outcome. What does that mean? Well, either you're going to get it again or you're not, irrespective of whether they got hormones or not. So the hormones did not show a significant increase in the risk of recurrence in these women. No difference in the two pools. Get it, don't get it, nothing to do with the presence of hormones. And we would have expected, if the hormones were a risk, we would have seen an increase in that population. Now, this is a subject of intense research. They will be expanding upon this and looking into this deeply, so stay tuned over the next coming of years. We may see more and more studies that, again, either continue to reinforce that, which will bring comfort to women who've gone down that road, or again, we'll see further study and we'll keep updating. One of the things with medicine is that it's something that over time we get better and better understandings. And sometimes that reinforces what we know to be true in the present. And sometimes that raises more questions or changes things over time. Just like the Women's Health Initiative of 2002 and 3. So that was the first outcome measure. The second outcome measure was, well, what about all-cause mortality? What about other diseases that are impacted by hormones? Well, the interesting thing is the women, and again, I don't think this is really surprising, this was kind of what people were expecting, is that the all-cause mortality went down. So taking hormone replacement reduced all-cause mortality, reduced the incidence and delayed onset of some of these other diseases that we know are helped by the use of hormone replacement. So this study as well, even on very high risk women, shows that there sometimes can be a role for hormones carefully under close supervision and personal guidance for women who have finished going through their journey with breast cancer. So something to talk about. New, upcoming. We still want more studies, but this is very positive, very reassuring. So again, we're really rethinking who we should be offering it to. Some of the other work that's coming out in it is that perhaps earlier intervention is indeed better. So the question is, well, when to initiate hormone therapy? Well, we definitely know, and I think all the different panels who look at this, and again, there's different groups who study hormones and when it should be started, but they've always kind of, the consensus, there's been agreement that usually sooner initiation is better. Even some of the more conservative organizations, again, would definitely recommend it within the first 10 years of menopause, and again, the sooner the better. So this is something that, again, is being explored to try to bring the hormone message to women at the best time to have the most impact on their preventative health and their future wellness. We know that the vast majority of bone loss happens during the later stages of perimenopause and the early stages postmenopause. So again, for that population and bone health, it's really important. We think the same for cardiovascular disease prevention as well too. So again, we may see broader recommendations coming down the pipeline about who to intervene with, when to intervene, earlier intervention, and the like. One of the other things that's very interesting is trying to help women with symptoms who are still technically in perimenopause. So, menopause is actually a definition based on time. So, it is the requirement of having no period, none, for a full 12 months makes you menopausal. You go 11 months and you have one, that's still perimenopause, not menopause. But we know already when periods become irregular and change, there's already changes in the hormone levels, and these can have sweeping effects on how people feel. And in fact, sometimes the most symptomatic period for women is actually that time frame before full definition of menopause, the perimenopausal time, because it doesn't seem to be any rules. So 1 month you could be crazy high with your estrogen, another month very, very low. Sometimes you ovulate and you have progesterone, and sometimes you don't. So again, hormone fluctuations can widely vary. So we do have some options to try to help women in perimenopause. So one of the common things we do is we consider just trying to normalize the progesterone. Usually progesterone is one of those hormones we see affected the earliest. So where does progesterone come from? I know grade 9 health class was a long time ago for most of us who are kind of at that age where we're contemplating perimenopause and menopause. So let's just review. So in the ovary contains all the follicles, which are the eggs before they're fully mature. They go through a little competitive process every month. A number of little follicles step up to the plate wanting to be the one that actually ovulates. And for the first couple of weeks of your cycle, they are growing like crazy until one of them becomes dominant. The one who really kind of comes out ahead as the forerunner, that's the one that will likely ovulate. So when that little egg is released at ovulation, the little grounding bed where it was growing actually becomes a brand new little gland called the corpus luteum. So the corpus luteum is actually what makes progesterone. So that's where the bulk of your progesterone comes from. So when you stop ovulating, when you run out of eggs at menopause, you also really, for most intents and purposes, you lose the vast bulk of your progesterone. You can still kind of make it in other areas very inefficiently, but the real lion's share comes from the corpus luteum. No corpus luteum, no significant progesterone. So what happens then is that the delicate balance between estrogen and progesterone gets thrown off. And again, that can produce quite a number of symptoms. So women who don't have enough progesterone or consistent progesterone or an imbalance between the ratios of estrogen to progesterone can really find themselves sometimes with a number of symptoms such as mood issues, anxiety, angst, irritability, sleep disturbances, bloating. They can have, again, if they're out of balance between estrogen and progesterone, more breast tenderness. They can get fibrocystic breast changes. They can get fibroids on their uterus. Their periods can be wildly erratic. They can be heavy. They can be light. They can be crampy. It can be all over the place. So again, a lot of irregularity around the perimenopause, and the closer you get to full menopause, the wilder things kind of come from being regulated early days to fully dysregulated right before menopause. So again, symptoms can really vary throughout that time frame. So one of the options we can do even before menopause, there are treatment options. And so one of the things that can be considered, and this is something to discuss with your doc or your nurse practitioner or your gynecologist, is whether you would be a good candidate for using progesterone during the time of your cycle where you'd normally have it, just to regulate you a little bit. So that would be the second half of the cycle. So you can, one option is to consider taking progesterone for the latter 2 weeks of your cycle and then off the first 2 weeks, on the second 2 weeks. And that can mimic what your body was previously doing on its own. And sometimes that just helps to keep you a little bit more regular during some of those transitional years, which just makes you feel better and again keeps everything working a little better until again everything stops, and then we can again look at whether we incorporate some of the other hormones. Also in that time frame, we do have other hormones that should at least be measured, being testosterone and DHEA, as well as your estrogen, because they can be affected as well. So they can be supplemented too. Sometimes women need a bit of estrogen in perimenopause, but the most common one is the progesterone. Now, it isn't just all about the sex hormones, estrogen and progesterone. A really other key consideration in anyone's state where they're considering hormone replacement is also to consider their cortisol or stress levels, as well as their adrenal hormones, cortisol and their DHEA. These hormones, particularly the impact from cortisol, people who have a lot of issues with cortisol can have difficulty getting regulated with their other hormones. There's almost like a hormonal hierarchy where right at the top is cortisol, the stress hormone. Underneath that, I would probably lump in thyroid. And then from there, you get into the sex hormones, the estrogen, the progesterone, the testosterone, and the DHEA. So if you have a great deal of stress in your life, and stress can be mental stress, because goodness knows anybody who is sort of in that midlife is in what I call the sandwich generation. You've got older parents above who are needing help. You're still probably working. You have quasi-adult kids, so we'll define that loosely. So there's a lot of people needing you and calling on you while you still have your own responsibility. So lots and lots of mental stress. Not getting enough sleep at night is physical stress on your body. And so as your hormones change, well, that will impact on you physically. Just the health of your body overall, if you have other health issues, and sometimes around 40s and 50s, things start to crop up. So that can also affect you, your microbiome, your gut bacteria, very important, your gut health, as well as environmental exposure. So there are a lot of chemicals in some of the stuff that we come in contact with all the time. So plastics and non-stick cookware and things like that can create chemicals that are somewhat similar to the hormones we have, and we call those endocrine disruptors, and they can interfere too. So trying to do all those good basics that you've always heard about, that we always just sort of mention in passing, those things are really important. So trying to manage your stress, try to pick and choose your battles and not sweat the small stuff. There's good credibility in that advice. Trying to put yourself on some degree of a regular sleep schedule as well as you can, maybe easier some nights than others. We'll see how that goes. Trying to eat healthy. What does that look like? Well, again, something we sort of brush past very quickly, but a balanced diet. If you just want to look up something really quick, the most scientifically researched diet with good credibility is the Mediterranean diet. It is rich in colorful fruits and vegetables. You want to get a good amount, eat the rainbow, lots of color in your fruit and vegetables. You want to minimize processed food, even maybe a little lighter on the carbohydrates. You want a good amount of healthy protein and good healthy fats, the good ones. So those are things to look for in your diet, along with an abundance of fiber for your gut bacteria, a little bit of physical exercise, and again, things to de-stress yourself. So those are all important things to do, as well as looking at these hormones. So in order to have a healthy brain, a healthy body, and a healthy, happy life, it's a lot of work. So yeah, it's one of those things where you can find time to invest yourself and explore those. So I'm hoping today's discussion gave you a few kind of things to think about, maybe relook at the whole hormone picture. Consider chatting to your doctor about it. Again, perimenopause can start as early as 10 years before menopause, although most women it's sort of, the last sort of anywhere 3 to 6 years before that final period. But if you're starting to notice a few changes, maybe check in. If you had concern about hormones, maybe revisit some of that and start reading around and see if you have a comfort level. Most importantly, seek care from your primary caregiver. Ask those questions and advocate for yourself. And all those little simple things everyone says, get sleep, de-stress, eat healthy. Yeah, there's merit in that. Give that a little time and attention to when you can. So for this episode, I just want to thank you for watching. We're going to try to really keep current material on here and talk about what's new and important in health and in disease prevention and health promotion. So if these are topics you're interested in, we are going to try to be pretty consistent on lunch hour on Wednesdays. So from 12:15 to about 12:45. Below here is a little QR code that you can scan, and that will bring you in to follow us on our podcast. And we also have information on our website. So if you'd like a little more information on some of these different things, you can check there as well too. And again, ask those questions. And if you have interesting things you'd like to hear about on the podcast, please feel free to message. You can follow me here on our social media, DM me your questions, and again, maybe we can cover some of those topics as we go forward. So until next week, I wish all of you good health and live your best life, and we look forward to seeing you on the next episode of Longevanity.